Next, we'll review the cardiovascular disorders. Hypertension is a systolic reading greater than 140 or a diastolic reading greater than 90 or both. The systolic pressure measures the heart in contraction. The diastolic pressure measures it in relaxation. Obesity is a major factor in both the cause and the treatment of hypertension. Thiazide diuretics prescribed to reduce fluid retention induce hypokalemia. Note, a low sodium intake following the DASH diet is recommended. The Mediterranean diet may have a positive effect. It is rich in alpha-linoleic acid, high in monounsaturated fats, and includes olive oil, fruits, root vegetables, leafy greens, nuts, seeds, and red wine. Resveratrol, found in the skin of red grapes, may lower blood pressure. Atherosclerosis is a progressive narrowing of arteries. Fat deposits accumulate in the heart, brain, and legs. Coronary artery disease occurs when the arteries supplying blood to the heart muscle become hard and narrow due to plaque buildup. Ischemia is a local and temporary deficiency of blood caused by an obstruction, as from a thrombosis. Dyslipidemia includes hypertriglyceridemia and low levels of HDL. Fat is transported in the blood bound to proteins, forming lipoproteins. The chylomicron is composed of dietary fat and is made in the intestine. The other lipoproteins are made in the liver and adipose tissue from endogenous fat sources. The metabolic syndrome refers to the risk factors linked to insulin resistance, which often increase the risk for coronary events. Risk factors include hypertension, hyperlipidemia, hyperglycemia, low HDL, and high waist circumference. The National Cholesterol Education Program offers general guidelines in assessing and treating high blood lipid levels. High homocysteine levels are independent risk factors for CHD. Note the features of the Therapeutic Lifestyle Change Diet, which is endorsed by the American Heart Association. In heart failure, the weakened heart fails to maintain an adequate output of blood, resulting in a diminished flow of blood to the tissues. Fluid is held in the tissues rather than being returned to the circulation. This causes edema. The reduced flow of blood to the kidneys causes them to think something is wrong, so they secrete hormones that hold in sodium, which adds to the problem. Therapy may include digitalis, which makes the heart muscle work better as a pump. Restrict sodium as needed following the DASH diet. The functional unit of the renal system is the nephron. All blood passes through the nephron to be cleansed. It includes a tuft of capillaries called the glomerulus, held closely together by Bowman's capsule. This is connected to a tubular structure through which the filtrate passes. Major nutrient absorption takes place in the proximal tubular section. Water and sodium balance are regulated in the loop of Henle, and acid-base balance in the distal tubules. The first function of the nephron is filtration. As blood passes through the glomerulus, red blood cells and protein remain in the blood and are returned to the general circulation. All else filters through the tubules. The nephron absorbs most water and electrolytes as they pass through the tubules. It excretes wastes and secretes hormones and ions. Note the hormones involved in renal function. Vasopressin from the hypothalamus gland, also known as ADH, elevates blood pressure. Renin, which is formed within the kidney and secreted by the glomerulus, acts as a vasoconstrictor, elevating blood pressure. Erythropoietin, also produced within the kidney, stimulates the bone marrow to produce red blood cells. Note, renal disease decreases the glomerular filtration and creatinine clearance rates. Both of these are urine tests. Renal disease increases the serum creatinine and the BUN, both of which are blood tests. Note, with acute kidney injury, a BUN to creatinine ratio of greater than 20:1 indicates a pre-renal state in which BUN reabsorption is increased due to acute kidney damage. This condition may be reversible and may not require dialysis treatment. A ratio of less than 10:1 suggests reduced BUN reabsorption due to renal damage and often suggests the need for dialysis therapy. The renal solute load measures the solutes excreted in 1 liter of urine. Note, it mainly measures nitrogen and sodium. 3 manifestations of renal disease are anemia, and upset in blood pressure, and decreased activation of vitamin D. Renal calculi are kidney stones. Note, a high fluid intake is needed to dilute the urine and prevent further stone formation. The most common stones are made of calcium oxalate. They are treated with an adequate calcium intake and a low oxalate diet. The minerals in food are not oxidized in metabolism. They form a residue that is excreted in the urine as an ash. The composition of the diet can be altered to change the pH of the ash. To prevent the development of acidic stones, create an alkaline ash in the urine by adding vegetables and fruits to the diet. To create an acid ash, to prevent the development of alkaline stones, add meat, fish, eggs, and cheese. Acute renal failure is a sudden shutdown of renal function, usually due to trauma. The symptoms are oliguria and azotemia. Oliguria is a urine output of less than 500 milliliters. Azotemia is an increase in urea in the blood. Begin with a protein restriction to postpone dialysis. Advance as renal function improves. Provide adequate calories to spare protein. In nephrosis, the primary defect is in the basement membrane of the glomerulus, which permits the escape of large amounts of protein into the filtrate. Note the symptoms are albuminuria and hyperlipidemia. Note the nutritional therapy. Protein intake is controlled and fat intake is restricted. In chronic kidney disease, anemia may result from a lack of the hormone erythropoietin. Provide adequate calories, restrict sodium if needed, and note when to restrict protein intake. In end-stage renal disease, few functioning nephrons remain. Nitrogen is retained, requiring a very low protein intake. Provide mostly high biologic value proteins and increase the caloric intake. The goals are to control edema and prevent nutritional deficiencies. With dialysis, the diet can be liberalized. Note the protein and calorie needs for the hemodialysis and peritoneal dialysis patient. Next, we'll review diabetes. Type 1 is insulin deficient. Patients depend on exogenous insulin. Type 2 is insulin resistant with a relative insulin deficiency. Note the normal blood glucose reading and those associated with diabetes. The glucose tolerance test is a blood test. Note the difference between the curve of a non-diabetic with that of a diabetic. Note, glycosylated hemoglobin measures the amount of hemoglobin that is carrying glucose. Note the goal for those with diabetes. This test gives you information about how the patient's glucose control has been during the past 2 to 3 months. A high concentration of glucose forms a chemical bond with hemoglobin. The longer the blood glucose level is high, the higher the hemoglobin A1C will be. Note, the therapeutic goal for all diabetics is to reach and maintain normal blood glucose levels. Optimum serum lipid levels and blood pressure goals are included. Strategies for managing type 1 diabetes include monitor blood glucose and adjust insulin doses as needed. With fixed daily doses of insulin, be consistent with intake of carbohydrate. For planned exercise, adjust insulin dosage. Note the risk factors for gestational diabetes. This condition increases the risk of fetal macrosomia, large for gestational age, and fetal hypoglycemia at birth. The glycemic index compares the blood glucose response of a food to a standard glucose load. Note the exchange lists. You may be asked to calculate the carbohydrate, protein, and fat grams in a given meal. Another way to help your patient control their intake is with the carbohydrate counting system. Here, you outline how many carbohydrate choices they may select for meals and snacks. One carbohydrate choice is equal to 15 grams. Note the types of insulin, their onset times, and durations. Rapid-acting and short-acting insulins provide a burst of insulin to cover the meal about to be eaten. Intermediate-acting insulin requires a bedtime snack that has both a carbohydrate and a protein. Oral glucose-lowering medications include glucotrol, which promotes insulin secretion, and glucophage, which enhances insulin action. Note the dawn phenomenon is a natural increase in early morning blood glucose and insulin requirements. It is due to increased glucose production in the liver following an overnight fast. One of the complications of uncontrolled diabetes is acute ketoacidosis. This is due to an insulin deficiency or excess carbohydrate intake. Note the symptoms of dehydration and a rapid pulse. Note the treatment is insulin and rehydration. Acute hypoglycemia is associated with a slow pulse and hunger. Note the treatment is 15 grams of glucose consumed in any form. Wait 15 minutes and check again. If needed, provide an additional 15 grams. Long-term consequences of uncontrolled diabetes include neuropathy, retinopathy, and nephropathy. That ends the section on diabetes. The next condition, postprandial or reactive hypoglycemia, is caused by excess insulin production or increased insulin sensitivity. Note, the goal is to prevent a marked rise in blood glucose that would stimulate more insulin production. Note, avoid simple sugars and eat several small meals, spreading carbohydrate intake throughout the day. Addison's disease is due to a deficiency of adrenal hormones. Results are hypoglycemia, sodium loss, and tissue wasting. The main therapy is hormonal replacement. The diet should provide frequent, high-protein, high-carbohydrate feedings liberal in salt. Note the differences between the two thyroid disorders. In hyperthyroidism, both T3 and T4 levels are elevated. The increase in BMR leads to weight loss. In hypothyroidism, the T4 is low, but the T3 may be normal. A decrease in the BMR leads to weight gain. Goiter is an enlargement of the thyroid gland due to insufficient production of the thyroid hormone. If the deficiency is due to a lack of dietary iodine, it is called endemic goiter. The diet must include iodized salt and be free of goitrogens, which are foods of the cabbage family, like Brussels sprouts. Gout is due to the abnormal metabolism of purines, resulting in an increase in serum uric acid. This deposits in joints, causing swelling and pain. A low purine diet may not be effective because the body makes purines. Galactosemia is an inborn error of metabolism and is caused by a missing enzyme that, note, would have converted galactose into glucose. Note, this condition is treated solely by diet therapy, galactose and lactose-free. In urea cycle defects, the body is unable to synthesize urea, resulting in ammonia accumulation. Note the diet has a protein restriction based on tolerance to lower the blood ammonia level. In PKU, the missing enzyme is phenylalanine hydroxylase, which would have converted phenylalanine into tyrosine. In its absence, phenylalanine accumulates. Note it is treated with a low phenylalanine diet. The need for phenylalanine decreases with age and during an infection. An infection causes tissue catabolism, releasing phenylalanine into the blood. Note, children with PKU may have a higher incidence of dental caries because their intake is high in carbohydrate and low in protein. Note, glycogen storage disease is caused by a deficiency of glucose 6-phosphatase. In its absence, the liver is unable to convert glycogen back into glucose, resulting in hypoglycemia. The homocystinuриas are treatable inherited disorders of amino acid metabolism. They are associated with low levels of folate, vitamin B12, and pyridoxine. Note, the treatment is to provide high doses of these 3 vitamins. Maple syrup urine disease is an inborn error of metabolism of the branch-chain amino acids, leucine, isoleucine, and valine. Restrict the branch-chain amino acids and provide adequate energy from carbohydrate and fat to spare protein. Note the diet for arthritis is regular and well-balanced. Some may develop a normocytic anemia. This is not related to the diet, so is not treated with iron supplements. It is a result of the inflammatory process preventing the reuse of iron. Lupus and the medications used affect nutrient metabolism, needs, and excretion, but no specific dietary guidelines exist. Tailor needs to individual patients. Some may have anemia associated with inflammation or symptoms of celiac disease. Osteoporosis occurs when loss of bone density is so acute that the skeleton is unable to sustain ordinary stress. Causes include protein malnutrition, lack of exercise, and a decline in estrogen. The result is a reduction in the amount of bone. The treatment may include hormonal replacement, weight-bearing exercise, and vitamin D and calcium supplements. Note, most at risk are elderly, frail, white females. Osteomalacia is a bone disease due to a vitamin D deficiency. It is treated with vitamin D and calcium supplements. Epilepsy is a seizure disorder treated with anticonvulsant drugs like phenytoin, which interferes with calcium absorption, so supplement with vitamin D. Note, take the drug away from food, so hold tube feedings. Alternative treatment includes the ketogenic diet. Note the classic form provides a very high-fat, very low carbohydrate intake in the ratio of 4 grams of fat for every 1 gram of carbohydrate and protein. Note the supplements needed. Cerebral palsy from brain damage results in inadequate control over the voluntary muscles. Note the 2 types. In the spastic form, there is limited activity resulting in obesity. In the athetoid form, constant worm-like motions of the limbs require the use of finger foods that can be eaten without utensils. The immobilization process resulting in paralysis decreases the ability of the body to absorb calcium. There is also a loss of nitrogen in the urine. Patients with decubitus ulcers often have low serum albumin and calcium levels. Note, the nutritional support should include a high protein, high calorie intake with a normal intake of calcium and adequate fluids. Supplemental vitamin C and zinc may be recommended. One of the experimental approaches to the treatment of hyperactivity is the Feingold diet, which restricts artificial flavors, colors, and salicylates. The efficacy of this plan has not been proven. Positive results may be due to the placebo effect. The special attention provided in the study led to improved behavior. Sugar also does not cause hyperactivity. When caring for one with Alzheimer's disease, avoid distractions during mealtimes. Encourage self-feeding, offering 1 course at a time. Anemia is a decrease in total red cell mass due to fewer blood cells or to smaller cells which contain less hemoglobin. Note the differences between the 2 major types. Microcytic hypochromic anemia presents with small, pale cells and is due to an iron deficiency. Anemias with a few large cells filled with hemoglobin are macrocytic. They are due to a deficiency of folate or vitamin B12. Looking at the lab values, in the microcytic form, all values other than the red blood cell count are low. The MCV, which estimates the average cell size, is low, indicating the cells are small. The MCH, measuring the amount of hemoglobin per cell, is also low, indicating the cells are pale. Microcytic, hypochromic, small and pale. In macrocytic anemia, the MCV and the MCH levels are high, indicating the cells are large and filled with hemoglobin, so are dark red. Note the normal ranges for MCV and MCH levels. The AG-AB reaction occurs as a natural protective mechanism against foreign substances. When an antigen enters the body, an antibody reacts to it. This is the response to foreign substances like dust or flowers. An immunoglobulin E-mediated reaction occurs when you react to normally harmless food protein. Note the most common food allergens. The RAST test is done outside the body. Rice is the food least likely to cause an allergy. Following fevers and infections, fluid loss may occur, leading to dehydration. Note the BMR increases 7% for each degree rise in temperature. Burns create a tremendous increase in the need for nutrients. There are massive losses of fluid, electrolytes, and protein. During the immediate shock period, the body is in catabolism, raising the BMR. Note the first goal is to replace fluids and electrolytes lost, then increase the calorie and protein intake. The ebb and flow refers to the metabolic response to injury, which is a hypermetabolic response following all types of trauma. The ebb phase, immediately following the injury, is associated with hypovolemia, shock, and tissue hypoxia. The flow phase follows fluid resuscitation and return of oxygen transport. A release of the catecholamine epinephrine suppresses insulin. Note the results of physiologic trauma. The effects of cancer on nutritional status include protein-calorie malnutrition and fluid and electrolyte imbalance. Those with altered taste acuity may benefit from added flavorings and seasonings. Meat aversions may require the elimination of red meat. Oral infections may be due to thrush. Note, avoid spicy, strongly flavored, and acidic foods. Provide bland liquids, soft foods, and chilled or frozen foods. Both radiation and chemotherapy adversely affect the function of the GI tract. Xerostomia is a dry mouth from lack of saliva production. Provide moist foods with sauces and gravies. Mucositis is an inflammation of the mucous membranes lining the oropharynx and esophagus. Intake guidelines include bland liquids and soft solids. Stomatitis from a riboflavin deficiency may present as cracks in the skin at the corners of the mouth. Starvation of both protein and calories leads to marasmus, diagnosed with anthropometric measurements. Note, iatrogenic malnutrition refers to the protein-calorie malnutrition brought on by treatments, medications, and hospitalization. Nutritional support for anorexia nervosa begins with correcting electrolyte imbalance, especially potassium. Include regular meal times, a varied and moderate intake with a gradual reintroduction of foods feared the most. Plan this with the patient. Focus on the health benefits and life-sustaining aspects of food. Give them a reason to eat. Because the refeeding process increases the workload of the heart, it should proceed slowly. Bulimia is the gorging and vomiting syndrome. Patients usually maintain close to their normal body weight. The physical complications that occur are damage to the throat from forced vomiting and rectal bleeding due to laxative abuse. Next, we'll review obesity. Note, obesity begins at a BMI of 30. There are about 3,500 calories per pound of body fat. To lose 1 pound per week, reduce intake by 500 calories per day. Most of the rapid weight loss that occurs initially with any diet is water loss. As glycogen from the liver is pulled out as an energy source, the water in which it is stored is also released. Note, weight maintenance is usually recommended as intervention for overweight children. The spot weight loss theory is a belief that localized exercise reduces fat stores in that active area. Research does not support this. There is no evidence that the fat pad surrounding the exercising muscle is used to any greater degree than fat pads throughout the body. When a dieter reaches a plateau, which means they stop losing weight, it is because the BMR has dropped to reflect the loss of weight. Note, healthy obese individuals often have an increased level of LDL. Note, bariatric surgery may be treatment for class 3 obesity with a BMI of 40 or greater, or a BMI of 35 or greater with comorbidities. Gastric bypass and gastroplasty reduce the amount of food that can be eaten at one time and produce early satiety. The Roux-en-Y gastric bypass connects a small opening in the upper stomach to the small intestine by means of an intestinal loop. Because the lower part of the stomach is omitted, the dumping syndrome may develop. Nutritional monitoring following gastric bypass should include potential anemia and deficiencies of potassium, magnesium, folate, and vitamin B12. Supplementation is necessary. Gastroplasty uses staples to create a small gastric pouch, leaving only a small opening into the distal stomach. Patients progress from liquids to pureed to soft foods to regular small meals and snacks. In gastric banding, the band creating the reduced stomach pouch can be adjusted so that the opening to the rest of the stomach can be enlarged or reduced. Patients who undergo banding will not require folic acid, iron, or B12 replacements. The Prader-Willi syndrome is a congenital disorder resulting in obesity, hypogonadism, and failure to thrive. Patients have decreased energy requirements but do not sense satiety. Note, the best treatment is to control their access to food. Dental caries are caused by acids that demineralize the surface of the tooth. When the pH in the mouth drops below 5.5, there is enough acid to damage the enamel. Foods with a low cariogenic potential, that is, those least likely to cause cavities, are those with a pH greater than 6. Note, sorbitol does not cause cavities. Fluorine is capable of controlling dental caries. Note the recommendations. Note, an infant should not be put down for a nap with a bottle. Stomatitis is an inflammation of the mouth from a riboflavin deficiency. Note, achalasia is a disorder of lower esophageal sphincter motility. The sphincter does not relax and open upon swallowing, causing dysphagia. Note, the diet for dysphagia begins with pureed, moist, thick foods. Pregnancy-induced hypertension occurs around the 20th week of pregnancy. Note, a sodium restriction is not recommended for prevention or control of PIH. The increased fluid retention that is normal during pregnancy increases the body's demand for sodium. Hyperemesis gravidarum is the severe nausea and vomiting that may occur during pregnancy. It is treated with bed rest. The AIDS syndrome leads to diarrhea and weight loss. Because AIDS patients are prone to foodborne illness, some may benefit from the low bacteria or neutropenic diet, which eliminates raw food. Pediatric HIV interventions include high calorie, high protein, with supplements needed for weight gain. Chronic obstructive pulmonary disease is a chronic obstruction of airflow through the lungs. Indirect calorimetry should be used to determine energy needs to provide sufficient but not excessive calories. Nutritional therapy should replete the patient and help them maintain normal weight but do not overfeed. Respiratory failure may follow advanced COPD. Here, the lungs are no longer able to exchange gases. The nutritional goal is to maintain a stable weight and preserve lean body mass. Enteral formulas are used for patients whose GI tract functions, but they are not able to consume an adequate intake. They are classified as standard polymeric, elemental, predigested, chemically defined, or specialized. Lecithin may be added as an emulsifier. Modular formulas are prepared by mixing individual nutrient components as needed, giving you great flexibility in tailoring the formula to patient needs. Note, elemental or chemically defined formulas are predigested and are used for patients with malabsorption. Note the components of these formulas. The more specialized the formula, the greater its cost. The opening or bore of the tube selected is based on the viscosity of the feeding. Enteral access depends on the anticipated length of time enteral feeding will be required, degree of risk for aspiration, patient's anatomy, their clinical status, and the presence of normal or abnormal digestion and absorption. Systems are open or closed. Hang time is the length of time an enteral formula is considered safe for delivery. Most allow a 4-hour hang time for open systems and 24 to 48 hours for closed systems. Short-term enteral access through a nasogastric tube is appropriate for those who need 3 to 4 weeks support with normal GI function. NG feedings can be delivered by bolus injection, intermittent, or continuous infusions. For those unable to tolerate gastric feedings, a nasoduodenal or nasojejunal tube is indicated. Note, transpyloric tubes are pushed by the pyloric valve into the intestine. They are used for comatose patients or for those without an active gag reflex. When enteral feedings are necessary for more than 3 to 4 weeks, gastrostomy or jejunostomy should be considered. Do not use blue dye to check tube placement. Note the water needs for a tube-fed patient. Provide 1 cc of water for every calorie ingested. 1 cal per cc formulas are 80 to 86% water. Complications associated with enteral feeding are listed. Peripheral parenteral nutrition is provided through the small surface veins. This is short-term therapy with minimum effect on nutritional status. Solutions contain dextrose, providing 3.4 calories per gram. Note, to determine the number of calories from a volume of dextrose, multiply the milliliters provided times the percent dextrose times 3.4. Protein and fat can also be included in a peripheral solution. Note, a 10% solution of intravenous fat provides 1.1 calories per cc. A 20% solution provides 2.0 cals per cc. Parenteral nutrition is used to achieve anabolism when patients are unable to eat by mouth and enteral feeding is not possible. Note the specific conditions when parenteral nutrition is appropriate. A peripherally inserted central catheter may be used for short or moderate-term infusion. Long-term central access is through the cephalic, subclavian, or internal jugular vein and fed into the superior vena cava. A major concern of parenteral nutrition is, note, the translocation of bacteria. When the gut is not used, it breaks down. Bacteria leave the GI tract, travel through the bloodstream, and induce sepsis. Parenteral solutions include protein in the ratio needed for anabolism, which is 1 gram of nitrogen for every 150 calories ingested. The percent concentration tells you the number of grams of protein found in 100 milliliters of the solution. So a 3% solution provides 3 grams of protein in 100 milliliters. Energy is provided as dextrose. Note, the maximum rate of dextrose infusion is 4 to 5 milligrams per kilo per minute to prevent hyperglycemia. This is the glucose utilization rate. Fat is added for energy and to prevent an essential fatty acid deficiency. As you transition a patient off parenteral support, introduce a small amount of full-strength enteral feeding at a low rate to establish tolerance, then advance slowly. Note, begin tapering the parenteral solution when enteral feedings are providing 1/3 to 1/2 of their nutrient requirements. When he can tolerate about 60% of needs enterally, then discontinue the parenteral support. Patients who require parenteral nutrition are frequently malnourished. The aggressive administration of nutrition can precipitate the refeeding syndrome. Starved cells take up nutrients, shifting potassium, phosphorus, and magnesium inside the cell. Note, this results in hypokalemia, hypophosphatemia, and hypomagnesemia. Overfeeding of dextrose may lead to hyperglycemia. Integrative medicine combines evidence-based complementary therapies with conventional treatments. Functional medicine addresses the whole person, not just symptoms, and looks at the underlying cause of disease, engaging the patient and the practitioner in a partnership for therapy. Holistic health views mental, physical, and spiritual aspects of life closely connected to and equally important with regard to treatment approaches. The dietary reference intakes reflect current population needs. Note, the RDAs are goals for healthy individuals. The EARs assess group nutritional adequacy. ULs offer guidance on safe upper limits of certain nutrients. Note, the dietary guidelines are designed to help prevent chronic disease and were written by the USDA and HHS. Community nutrition programs use these guidelines when developing their plans. Recommendations include: follow a healthy eating pattern throughout life, focus on variety, nutrient density, and amount, shift to healthier food and beverage choices, limit calories from added sugars and saturated fats, and reduce sodium intake. The USDA's Healthy Eating Index is a measure of overall diet quality. This measures how well we follow the recommendations. The My Plate food guidance system shows essential food groups. Recommendations include balancing calories, foods to increase, and foods to reduce. The Healthy People program identifies broad goals and specific objectives for improving the health of the public. Note, it focuses on disease prevention by changing behaviors. Note the 3 steps in planning programs in order: mission statement, goals, and objectives. Begin by developing a mission statement which describes the philosophy of the program. The needs or problem statement describes the current situation, who says it is a problem, and what will happen if nothing is done. Then state your goals and objectives. Note the differences between them. Goals are statements of broad direction and general purpose. In selecting goals, determine which health problems have nutritional implications, which are the current high-risk groups, and what are the most critical needs. Then develop measurable objectives, which are more defined and specific. They include specific target dates for completing specific projects. Evaluate alternative strategies available using cost-effectiveness analysis. The budget controls and coordinates the activities. It indicates how and at what rate money is to be expended. When preparing the budget, consider the items as listed. Public health departments derive a portion of their income from general revenue, taxes. Other sources of funding include federal, local, or foundation grants. Implementation of the program requires administrative support with a realistic budget, staff commitment to the goals and objectives, and support of the target population. Community-based interventions should work on some of the powerful cultural and social influences that are difficult for individuals to overcome on their own. Intervention relates to the 3 domains of learning: cognitive, affective, and psychomotor. One intervention strategy is to educate the community, increasing awareness and knowledge of sound nutrition practices. Explain scientifically sound information to the client so they understand the reasons for the recommended changes. When changing their attitudes, people must believe they can control what they eat. Another intervention occurs at the point where consumers make a choice: grocery store tours. Enabling makes it easier for people to act. Using the 4 P's of marketing, the program should be acceptable, easy to get to, reasonably priced, and promoted to sound interesting to make people want to join in. Another strategy, which involves psychomotor learning, is to help people develop the skills needed to make and sustain new habits, like how to budget, how to find the services they need. The 4th step in the nutrition care process, monitoring and evaluation, answers the question: is the nutrition intervention strategy working to resolve the nutrition diagnosis, its etiology, and/or signs and symptoms? Nutrition monitoring is the review or measurement of a selected nutrition care indicator. Nutrition evaluation is the systematic comparison of findings with goals or standards. The critical thinking skills needed include selecting appropriate indicators and measures, using appropriate reference standards for comparison, defining where the patient is now in terms of expected outcomes, and explaining variances from the expected outcomes. Data is collected and analyzed timely so performance can be adjusted and improved. The data is then used to create an outcomes management system. Evidence-based outcomes research documents the clinical effectiveness of medical nutrition therapy. The outcome categories are direct nutrition outcomes, clinical and health status outcomes, patient-centered outcomes, and healthcare use and cost outcomes. Nutrition care outcomes are the measurable results of nutrition care directly related to the nutrition diagnosis and the intervention goals. Nutrition care outcome indicators provide information about the type of progress made, when the nutrition problem is resolved, and what aspects of nutrition intervention are not working. Nutrition care outcomes represent results that the practitioner and nutrition care impacted independently. They can be linked to nutrition intervention goals. They are measurable and occur in a reasonable time period. They can be attributed to the nutrition care provided. They are logical stepping stones to other healthcare outcomes. Nutrition care outcomes are distinct from healthcare outcomes because they represent the nutrition professional's specific contribution to care. They are grouped into 4 categories: food and nutrition-related history, lab data and medical tests, anthropometrics, and nutrition-focused physical findings. Healthcare outcomes are of interest to healthcare providers, health systems, and payers. They include health and disease outcomes, changes in severity, duration, or course of a condition or disease, changes in risk level, and maintenance of health. Cost outcomes refer to changes in length of stay, ICU days, number of outpatient visits, treatment procedures, and medications. Patient outcomes are changes in indicators that reflect functional level, disability, and quality of life. Positive changes in nutrition care outcomes in turn improve other health outcomes. Documentation includes a statement of where the patient is now in terms of expected outcomes. It should include date and time, indicators measured, results, and method for obtaining the measurement, criteria to which the indicator is compared, factors facilitating or hampering progress, other positive or negative outcomes, and further plans for nutrition care, monitoring and follow-up, or discharge. Based on the findings, you make a decision to actively continue care or discharge the patient. If care is to be continued, the nutrition care process cycles back as necessary to assess, diagnose, and/or intervene as needed. This completes Domain 2.